Hello, everyone. My name is Laz Boros, and I'm the president of the Thyroid Foundation of Canada. I'd like to welcome you to our May 14th educational webinar. Our guest speaker today is Dr. Jesse Pasternak, who will be speaking on ultrasound-guided thermal ablation of thyroid nodules. Dr. Pasternak is an endocrine surgeon specializing in the surgical management of thyroid, parathyroid, and adrenal tumors. After obtaining his undergraduate degree at McGill University, he completed his medical school and residency at McMaster University in Hamilton. He then moved to San Francisco, California, where he trained as an Orlo Clark Fellow in endocrine surgery and oncology at UCSF. Dr. Pasternak also completed a master's degree at Harvard University with a focus on epidemiology. As a surgeon at the University Health Network, his clinical focus is minimally invasive endocrine surgery. As a research, he studies clinical endocrine surgery and health outcomes. Once the presentation has been completed, Dr. Pasternak will answer general questions about thermal ablation from the audience. Catherine Keene, our administrator, will be acting as producer for this webinar. This means that she will be managing the technical aspects of Zoom. Some of our board directors will also be assisting. Anista Primachardan will be looking after the QA section. Laurie Martin will assist us in the chat room. This event will be recorded and made available on our website later this week. A little bit of housekeeping before we begin. Today we're using the webinar functionality of Zoom. This means that you can see and hear the presenter and support team, but your audio and camera are not active, and we are not using the raised hand feature. You're able to communicate with the other attendees using the chat feature at the bottom of the screen, so please feel free to join in. If you do not wish to see the chat previews displayed at the bottom of your screen during the presentation, please click on the chat button arrow and deselect the Show Chat Previews option. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. At this point, we are ready to begin with Dr. Pasternak's presentation.
Thanks so much, Laz, and the whole group, really, for inviting me. It's really an honor to be here, and thanks so much, everybody, for taking time out to watch this. I'm just going to share my screen here so that we can. All right. So when I was asked to give a talk about RFA, or radiofrequency ablation for thyroid nodules, I thought that it'd probably be better to start a little bit further back to try to, get a sense of how people treat thyroid nodules. As many of you know, thyroid nodules are quite common, and I'll discuss that a little bit. So forgive me if I'm being a little bit more general initially, but I will get to all of your questions as well about RFA. I'm, as Laz said, I'm an endocrine surgeon, so I have a subspecialty within surgery of thyroid, parathyroid, and adrenal, and I only do those operations in my elective practice. So you can imagine, I do a ton of those, and this is a growing specialty across Canada. In the States, it's fairly established. Most academic centers have endocrine surgeons like me, but in Canada, it's growing. There are endocrine surgeons usually in your province, and if there isn't, or if you can't find one, I'm happy to take an email or call, and we can direct you to that. The American Association of Endocrine Surgeons is a group in the U.S. of which all the most of the academic endocrine surgeons in Canada, meaning the surgeons that work in university centers in Canada, usually are members of that group. So that can also be a resource for you. Overall, I'll go through some of the. Let me just go through my next slide. So I don't have any relevant disclosures to say. Overall, I'll go through a little bit of thyroid nodules, what they're about, how common are they, who they affect. And then I'll discuss a little bit about when we intervene on thyroid nodules. When do we do something when we need to do something about them. And then I'll mention a little bit about surgical options. I'll talk about RFA, but I'll also talk about that in the context of other things that we offer for thyroid nodules. And then I'll answer any questions that you have. So thyroid nodules are quite common. If I took an ultrasound and I went to the street and I ultrasound everybody, I work in downtown Toronto, so if I ultrasound everybody walking down Yonge Street over the course of an hour, 50% of people would have a thyroid nodule in their neck. And as we get older, more of us have thyroid nodules. When we're 80 years old, 80% of us have thyroid nodules. The good news is that only a small percentage of thyroid nodules are thyroid cancer. And these are just some of the pictures of some of the famous people that you may have known that had thyroid cancer or that have been public about their thyroid cancer. But I suspect many, many more people in the public eye have had a thyroid cancer. And the good news is that it's quite uncommon to have a thyroid cancer, and it's even less common to have a clinically relevant thyroid cancer. Most thyroid cancers, as many of you know, are quite indolent and slow growing. That doesn't mean they don't need attention and to make sure that we treat them adequately. But most people that have thyroid cancer do quite reasonably well. There are subselected people that need extra attention and therapy, but it is quite common. The other thing that is interesting is that, and I don't have the slide here, but the Canadian Cancer Registry or the Canadian Cancer Society does review of what the most common types of thyroid cancers are, or most common types of cancers are in Canada. And thyroid cancer ranks as the most common type of thyroid cancer if you're a young woman. So young females, even more than breast cancer, it's actually thyroid cancer is the most common cancer. In older females, it's breast cancer, but in younger females, it's thyroid cancer. So we do have certain demographics that are at most high risk for this, and we do try to, at least my research tries to focus on trying to help those specific demographics. So as I said, thyroid nodules are very, very common. Even women not necessarily have increased risk of thyroid cancer, but they have increased risk of thyroid nodules. And we have a huge bias of 3 to 1, or even in some series is actually more than 3 to 1. So that's something that we always think about making sure we target in terms of our our therapy and diagnosis. So I'll talk a little bit about, when we need to do something about it. So the main reasons why we do something about thyroid nodules are 3. There's 3 main reasons. The first reason is related to symptoms. So some people have some symptoms in their throat related to the large thyroid nodule that's growing there. The second reason would be people that have thyroid nodules that make too much thyroid hormone. And you guys had a recent webinar of hypothyroidism, but this would be hyperthyroidism related to either toxic nodules or Graves' disease. And not necessarily surgery as the first line, but surgery is a part of some of the treatment for these. And then the last would be a thyroid cancer, which we talked a bit about just now. And overall, thyroid cancer does usually require operations, although there are some trials, including in Toronto, we do an active surveillance trial for tiny small thyroid cancer that can be observed. And these surveillance trials come from Japan, where the Japanese, large Japanese population of thyroid cancer patients actually have been monitored, and these have been going on for about 20 years. Not all patients, but some patients with small thyroid cancers are monitored over long periods of time, and patients do quite well. So most patients do require surgery or something related to intervention, but there are subselect people that don't require surgery. And so I'll talk a little bit about the symptoms first. So symptoms are usually the symptoms of pressure in the throat. We call this globus sensation. Dysphagia, which is difficulty swallowing, dyspnea, difficulty breathing, and hoarseness. Hoarseness is quite uncommon for thyroid nodules. Usually when people are hoarse and even if they have a thyroid nodule, it's usually related to something like reflux disease or postnasal drip, but hoarseness can be a cause of thyroid cancer, specifically that's grown into the nerve that supplies the vocal cord. Most patients that have a symptomatic thyroid nodule, it's usually difficulty swallowing, where they're swallowing a big pill. They swallow a big pill and it kind of is hard to kind of get through their throat. And the other is sometimes when they lie flat on their back, they feel something pushing on their throat. And these are the most common symptoms that people have. Generally, the bigger the thyroid nodule is, the more likely they'll have symptoms. And we start to see symptoms more commonly when thyroid nodules are kind of over 3 centimeters in size. So if you can imagine, like, your pinky fingernail is like 1 centimeter kind of thing. So, like, it's a reasonable size nodule, but it's still somewhat small when you think about, how big certain organs are in your body. This is a picture of somebody that has a real big thyroid nodule, but the reason why many people across the world have large thyroids is related to iodine deficiency. So when we're growing up and we're developing our organs, specifically our thyroid, we utilize a lot of iodine to make. We need the iodine to make thyroid hormone. And when you don't have the iodine, the body the body needs the thyroid hormone, and so the thyroid actually works overtime and gets really, really big. And that happens in certain areas in the world, specifically in areas that don't have iodine added to salt. But we in Canada actually add the salt. That's why you see iodized salt. We add iodine to salt so that we prevent this at all possible. There's other populations around the world, and even in Canada, certain populations throughout Canada that have high levels of goiter or large thyroid nodules in their family, irrespective of whether they have iodine deficiency or not. And so you just may get lucky to be a part of a family that has big thyroids, and many people in your family have had thyroid surgeries, perhaps. And this is somewhat common in certain areas within the Canadian landscape. And they can be associated with low thyroid levels. So you can have a huge thyroid, but no thyroid hormone being produced. And that's actually somewhat common. We have big thyroids that make a lot of thyroid hormones, so they cause hyperthyroidism. And then there are a lot of thyroid nodules and large thyroids that are big, and people have normal thyroid function. So, it really depends on the type of thyroid nodule or the large thyroid that you have in terms of what it's actually doing to your body. So, symptomatic thyroid nodules we talked about, they usually require big surgery. So I don't know if you've ever seen, and you can look it up online, but I was going to show some pictures of patients, but we're recording this. So I'm not going to put the patient pictures up, but basically you can see there's large incisions that you sometimes would have to happen to take these big thyroid nodules out, because you can't have a big thyroid nodule making a small incision in the skin and take the thyroid nodule out, because you still need to make it as big as the thyroid nodule. And some of these nodules are 4 or 5 centimeters in size, but even bigger, 6 centimeters, 8 centimeters, and you don't really want to have that big of an incision sometimes. And so that's why some type of other technology would be ideal. And I'm going to get to what it is, but this is like kind of the main demographic of people that would benefit from RFA, and I'll talk about that in a second. So there are a few different, we call these thyroid percutaneous ablative options. These are things that we don't necessarily need to make an incision in the skin, and we can still get rid of the thyroid in certain ways. And there's a few, I don't know if you can see my pointer, but there's a few that are available in certain places in the world, but not necessarily available in Canada. And I've worked with a few of these already in my career. One is laser ablation. There is some downsides to this. Microwave ablation, HIFU. We use HIFU in prostate and other types of places in the body. But these are not necessarily available in Canada right now, and they do have a lot of downsides compared to what the other available options are. Ethanol ablation is something that is available, and I do this sometimes. But the ethanol ablation is mostly for patients that have really big thyroid cysts. So if you have a fluid-filled nodule in your neck, which is basically just a cyst, it doesn't have many cells in it, then sometimes your doctor may aspirate it or remove the fluid from the nodule or from the cyst. The problem is that often returns, and often quite quickly. So ethanol or alcohol ablation can actually be used to stop the return of the fluid in those cysts. And then the last option is obviously radiofrequency ablation, and I'll talk about this. So RFA, or radiofrequency ablation of thyroids, has been around for over a decade. Actually, it's been around for a couple of decades, and it's actually been used in liver for many years. Liver tumors that can't be resected or excised by surgery. often will have intraoperative RFA where the radiologist or the surgeon will use a little probe, just like we're using in thyroid, and put it in the tumor and actually kill the tumor without having to take out the liver. But the thyroid RFA started, it was popularized by a radiologist in South Korea named Beck, and he has been doing this for a few years now, and it's currently available in multiple countries around the world, but it hasn't been available in Canada. And about 6 years ago, I saw that Beck was doing this, and I reviewed this at a few different meetings that I was at. And unfortunately, we didn't have it in Canada, so I spent a bunch of time. In fact, I spent the better past the last few years, 3 to 5 years, actually trying to figure out how to get this to Canada. And I helped with making sure that we had some ability to bring it to Canada, which required a lot of regulatory issues. As you know, Health Canada is the main driver to have new technology available for patients in Canada, and that's different than the FDA. People think about the FDA as something that the Federal Drug Administration, the American institution, which was popularized over the COVID pandemic, but really the FDA doesn't affect what's available in Canada, as many of you know. So the Canadian equivalent is the Health Canada agency, and that took a lot of time to get that available in Canada. And I really thank a lot of you for your strong advocacy in really trying to push this forward, because that really helped us a lot. And as you can see, this is one of the change.org petitions, and there are many other petitions out there to try to get this in Canada. So I'll just give you a little bit of an overview of what it is. So basically, if you need RFA, you come into the clinic. It's not an operating room procedure. You come into the clinic. We give you a gown just to put on, just so that we don't get any of this cleaning stuff on your clothes. Although some people, you could do it in your clothes if you needed to. We have a gown, so we don't really need to. And then we just put a little bit of cleaning solution on your neck. And then we put a bunch of drapes on, because we try to keep it as sterile as possible, just because we're putting needles into tissues. We put a bunch of local anesthetic, which is instilled into the area around the thyroid and in the skin, just to prevent people from having any pain. Sometimes people feel a bit of pushing, but most people don't feel any pain. And then you can see the surgeon or the person doing the procedure stands at the head of the bed, which is right near the patient's head. And then the generator and the water pumps and all that stuff are placed on the side, and we use the ultrasound to guide the needle, and I'll show you that in a second. Sometimes we can use like a benzodiazepine or some sort of sedation, or not sedation, but some sort of anxiolytic. So like people sometimes take like a Valium or something before the procedure, just to kind of, if you're get a little bit nervous, kind of getting biopsies or needles in your neck. Obviously, anybody would be a bit squeamish, so sometimes people can take that, but mostly we don't need any anesthetic. And it's pretty short procedure time. For smaller nodules, it can be 10-20 minutes. For larger nodules, it can be up to an hour or so, but it's certainly not like hours and hours of this procedure. And people recover very well. They go home within 20-30 minutes. And sometimes they have a bit of bruising in the area from some of the local, but most people feel better. Some people have they feel like something a little bit stuck in their throat for a couple of days just from the bruising in the area. But really, some people don't even notice it. They're home, doing their normal business the next day. So again, this is just a video of how this is happening in real time, and you can see this long thing is the needle or the probe that we use. The ultrasound's coming from the top, and we just basically withdraw, and you can see the nodule actually become desiccated or burnt, like barbecued almost from the inside. It doesn't smell or anything like that. You just hear sometimes you hear a bit popping. I don't have the sound on, but you can hear it popping a bit. You can hear the tissue just become desiccated while you're actually sitting there. You don't feel it. It doesn't hurt, but it just is quite an interesting procedure where all this nodule is now just becoming just scar, and then over time, the idea is that over time it just basically evolves into nothing, and then the nodule shrinks. So the American data, this is from some of my friends who are doing this in the US. And you can see that after the first, this is a study that was published in Annals of Surgery, which is one of the top surgical journals in the academic space. And this is a nice study showing that the volume reduction after 1 month can be around 50%. Some of my patients, that I've done in our clinic, after a month, we have 30–40% decreases in the size after actually 3 weeks. So it's quite good. And then after 6 to 12 months, you can see up to 75% decrease. So if you think about it, like a 4 or 5 centimeter nodule, that's causing, that's bulky in your neck, that's causing a bit of pressure when you swallow big pills. It can go down by 75% in size within 6 months to a year. And it's no longer bulky and it's no longer causing your symptoms. So that's kind of the ideal scenario for not needing a surgical intervention. So I talked about the symptoms. Now, what about toxic nodules or Graves? So in toxic nodules, as this is some of you know, these are some people that have come out with Graves or hyperthyroidism. But I'm sure many more people have this. They just haven't been vocal about it. But Graves' disease is not an indication for RFA. However, toxic nodules, so if you have one nodule, so this bottom image with multiple hot nodules probably would not be ideal for RFA. But this top picture with the one hot nodule would be ideal for RFA because you can actually burn just that hot nodule, and then the other thyroid parenchyma would come and take its place and be able to be adequate for your thyroid function. So the effectiveness for hot nodules, about 50% of people have normal thyroid function, so they've had hyperthyroidism prior to the procedure, and about half of them will have normal thyroid function within a year. Because sometimes if you burn the hot thyroid tissue, sometimes you have a bit of fluctuation in the thyroid levels for a while as the regular thyroid just gets back online. It's been usually suppressed for a while, so it sometimes takes a bit of time for it to come back online. About 50% have that come back online within a year. And then the last thing, cancer. So this would be like a thyroid nodule that would be, let's say it was biopsied as a cancer. So most thyroid nodules that are thyroid cancers would usually require a surgery. And the American Thyroid Association recommends at least partial thyroidectomy or thyroid lobectomy for a thyroid cancer. I published a paper a few years ago now in the Canadian Medical Association Journal, actually suggesting that we should do partial thyroidectomy or half the thyroid being taken out for thyroid cancer, although some places in Canada are still taking out the whole thing. And as we disseminate some of that information, we'll be taking out less and less thyroids for thyroid cancer. But certainly the thyroid hypothyroidism rates after thyroid surgery are actually reasonable. So up to 60% of people after partial thyroidectomy need a thyroid pill after surgery. So we are kind of looking for other options that are as equivalent with an oncologic process. And certainly when you take a thyroid out, for the most part in Canada right now, you're making a scar in the neck, and that's kind of something that's kind of the classical way. At my center at UHN, we actually are the only place in Canada offering a little bit of an option. And I know this talk is not on that, but I figured this is the same group that would be interested in this. So we're offering something called transoral endoscopic thyroidectomy. And I just want to show you a video of why this may be helpful. And some of the patients that we've offered this to have been in this scenario. This is from the University of Chicago. One of my colleagues put this out a few years ago. I'll just play a few minutes of this just so you see some of the options.
Reminded of my own mortality. It's a constant reminder of the time that I had cancer. So aesthetically, it wasn't a big thing for me, but just to have that constant reminder, I didn't want it.
Today, Sherry Kane plays with her son Corbin, and it's like nothing ever happened. She has no reminder of her surgery due to thyroid cancer because of a new procedure at the University of Chicago Medicine called a transoral thyroidectomy.
Right now, the best candidates are those that have smaller tumors or well-localized parathyroids.
So that's I'll just stop that. That's Ray Grogan. He's one of my colleagues. Right now he's in Texas, but but he started doing the most amount of these, and around the same time he started doing them. I started doing them a few years ago, and so we do some of these. Myself and some of my colleagues at the Toronto General, we do these, and the Toronto Western UHN, we do these for certain types of patients. So, you know, in patients that have get really bad scars, that need surgery, we do offer this operation to some people. So I think that's something that people should be aware of. I was going to show a video again, but the incision is just in the lip, and the complication rates are exactly the same as the open surgery. The only difference is some people have a bit of numbness in their chin after surgery, but it almost always goes away after kind of a short period of time. And you can ask me questions about this after, we can talk about it. So I'll just go back to RFA for a second. So RFA, we talked about how hot nodules are really could be used for RFA, but the main indication would be large symptomatic nodules, those big nodules that are pushing on the throat. And then small thyroid cancer neoplasms, we don't have an indication, at least I'm not advocating this for RFA, although we are offering a trial for some patients with small thyroid nodules that are indeterminate or that are thyroid cancers that would meet criteria for RFA, and that's through a study only. That's not through clinical indication. So what are the risks of surgery? And we can just balance the risks benefits. So the risks of surgery, as you guys may have known, is that the complication rates are quite high for surgery. So in low volume surgeons, a quarter of the patients having total thyroidectomy will have a complication. And even in lobectomy rates in high volume surgeons is still about 7.5%. These are academic high volume surgeons doing more than 100 thyroidectomy a year. Is still quite reasonable in terms of complications. So complication rates are high for thyroid surgery. Now that's not like big complication rates. That's just, you know, things that may affect people after surgery, specifically low thyroid levels. That's something that we worry about after thyroid surgery. So these are issues that we just really want to get rid of by figuring out some new technology. And as I mentioned before, hypothyroidism rates after thyroid lobe, so 20% of people for benign thyroid nodules, and about 66 or 2/3 of patients after malignant thyroid nodules. We put a paper out for quality of life of patients after thyroid surgery. We do a lot of research on this because I think that, you know, because patients do so well from thyroid cancer, we really have to focus on how patients do from a quality of life standpoint, because that's probably what's going to determine how they're going to live the rest of their life. And, you know, we do have a high number of patients that have low thyroid levels after thyroid surgery, as many of you know. But the risks of RFA are actually much lower. So this is a large study published 2017 showing that they had nobody in their patient list who actually had permanent hypothyroidism. So even if it does happen in these patients that get RFA, it is very, very uncommon when you consider it for 2/3 versus none. I mean, these are things that we have to kind of think about when we're trying to offer patients certain types of treatment, and we want to make sure that we give them we understand what the risks benefits are, and not just, you know, what we always did. We should continue to do, because just so you know, the current thyroidectomy, as many of you know, was popularized by a guy named Coker, who actually won the Nobel Prize for taking out thyroids in a special way. He did a bunch of advancements in thyroid surgery, and he won the Nobel Prize in the early 1900s. So if we're thinking about the fact that we don't really do much difference in our thyroid surgery in over 100 years, it's time for us to kind of change our thought process about how do we treat thyroids. And we did the first RFA in Canada last month. And this is us, we had a big team. This is us doing it as I showed you. This patient's completely awake. This was you can see this tiny little scar in the middle of their neck, or not a scar, but a little dot that was completely gone after a few weeks. And she did really well. So this is our the team was really awesome. We have a great group of people at our group at UHN that do this. All right, that's it. That's all I'm going to tell you. This is my son with the llamas, and I will ask you if you do chime in if you want to chime in, you can say where you think the thyroid gland is on these llamas. Is it in the orange area, or is it in the green area at the bottom of the neck? So it's hard. Everyone kind of gets this mixed up. So with that, I'll hand it back to Laz and the group, and happy to take some questions.
Great. Okay, Dr. Pasternak, could I ask you to stop sharing your slides so we can get into the other mode? Ha, great. Okay, Anista will now read your questions for Dr. Pasternak. Please remember, use only the Q&A function, a feature located at the bottom of your screen for your questions. We will not respond to questions from the chat feature or from emails. Anista?
Thank you for that wonderful talk, Dr. Pasternak. I'll now begin with our Q&A. Our first question is, what is the upper limit of nodule size for RFA?
It's a good question. There really isn't an upper limit. The issue really remains that thyroid nodules that go into the chest cannot be seen by an ultrasound. So if you can't see it with an ultrasound, you can't RFA it. So I would say that it's not necessarily the size. Like that patient that I showed that had a big thyroid nodule that's popping out of her neck, that would be a reasonable candidate for RFA. Presumably it's benign. We usually do 2 benign biopsies prior to doing RFA, or 1 biopsy and looking quite non-suspicious on ultrasound. But if there was a big component that went to the chest, then it would not be a candidate for RFA.
Thank you. And our second question is, how do we know if we are iodine deficient?
That's a good question. In Canada, the iodine deficiency is essentially not an issue. It's very uncommon, and most people that are above, after their childhood level, don't actually have iodine as a big problem in their diet. The iodine deficiency causing large thyroid nodules affects us when we're young. So if we have a normal thyroid and then we are older and we have an iodine deficient diet, you won't necessarily have a large thyroid that grows at that time. You may just have hypothyroidism. But the thyroid nodule caused from iodine deficiency is usually from the development phase when we're children and we're growing to become adults.
Right, thank you. The next question asks, will embolization for thyroid nodules be available as an option in Canada in the near future?
RFA is available now in our center, and it's starting to roll out throughout the Canadian landscape. I know that there are some centers in Montreal, Vancouver, Calgary, others looking at this, incorporating this into their practice. And as we increase the, and I can keep Laz and the rest of the foundation involved in as we increase the amount of people that are offering this. But certainly it is available right now, but unfortunately it's only in Toronto.
Thank you. Another question asks, what's the side effects of the radioablation after popping the nodules? The liquid inside the nodules, where does it go when it pops, and does it affect other organs?
Yeah, good question. The tissue itself just desiccates and is absorbed by the body, just like if you have, allergies, and the allergen pollen and that stuff just gets brought into, and you sniff it in, and it gets brought into the lymph nodes, and lymph nodes just get rid of it in your body through normal channels. So your body just absorbs all that stuff and then gets rid of it the way that it gets rid of other toxins in your body. Very not dangerous at all.
Great, thank you. After removing the gland, is the treatment the same as hypothyroidism? And is there any other effects after removing the gland than the symptoms of hypothyroidism?
So we don't remove the gland in RFA. The RFA is, the idea of RFA is that you burn the nodule itself and you don't take out normal thyroid tissue around the nodule. When we do thyroid surgery, like let's say taking out half the thyroid, the issue with doing that is that if the nodule is not encompassing the entire half of the thyroid, then you're removing some normal bits of thyroid tissue. And that's why the RFA is more of a directed approach, where you actually just desiccate the thyroid nodule itself. In a thyroid operation, either the transoral thyroidectomy without the scars or the open thyroidectomy that many of you have access to right now across Canada, that type of thyroid surgery takes out half of the thyroid if you're going to take out half or the whole thyroid. And then if you develop, if you take out the whole thyroid, certainly you'll need thyroid hormone as a supplementation. But if you take half the thyroid, a large portion, I spoke about that a little bit, about 20% of people that have a benign thyroid nodule and about up to 2/3 of people that have a malignant thyroid nodule need a thyroid pill just to allow the rest of the thyroid to give it a little bit of a bump so that it actually has enough thyroid functions or thyroid hormone levels so that your thyroid functions normal in your body and you don't feel kind of all the symptoms of hypothyroidism, which I know that you guys had a talk on, so I won't bore you with.
Thank you. Do you recommend RFA for a 8 mm papillary thyroid cancer nodule?
That's a good question. So microcarcinomas, I talked a little bit about how we can do active surveillance for those. And the American Thyroid Association guideline in 2015 actually mentioned that active surveillance for microcarcinomas is an adequate option for patients. If you're interested in it, you can go to the American Thyroid Association website, and they do have the guidelines that are posted, and you can see that they recommend either lobectomy or active surveillance for microcarcinomas. That being said, the RFA is being used in a trial purpose for microcarcinomas, and we have a trial running for exactly those patients. There's a few trials like that running in the US. One of my colleagues in Columbia, at Columbia University in New York, also is running a trial like that. So I as a clinically recommended tool, the current recommendation is either thyroid lobectomy or active surveillance. But as an investigational tool through research purposes, we could offer RFA.
Thank you. When the thyroid is malignant, when the thyroid node is malignant, how would you treat it? And do you use thyrospec DNA RNA testing to help get a diagnosis?
Okay, so you're asking a little bit about molecular testing for diagnosis of thyroid nodules. So I'll just have a bit of a background for people watching that may not have the background of this question. When you find a thyroid nodule, there are different things that we do to work it up to determine if it's thyroid cancer or not. So a thyroid nodule that is suspicious on the ultrasound may require a biopsy to find out if it's thyroid cancer. And not all thyroid nodules need biopsy by any means. In fact, most thyroid nodules probably shouldn't get a biopsy because it complicates things a little bit when you do a biopsy for a thyroid nodule, especially when that's small and non-concerning. When you do a biopsy, however, for a thyroid nodule that's concerning, that requires a certain extra amount of diagnosis, where you want to know if it's thyroid cancer or not, there are different outcomes from that biopsy that you can find that tell us how suspicious it is of a thyroid cancer or not. Unfortunately, when we do a biopsy, we can't get a result of yes, it's cancer or no, it's not cancer. That doesn't exist, although there are a possibility of you knowing that it's cancer or not cancer. But many thyroid nodules that are biopsied, in fact, up to 40% of thyroid nodules that are biopsied are in this indeterminate area, which is between the thyroid cancer and the benign level. And when it's in that indeterminate nodule category, there are certain ways that we can potentially figure out if it's more considered to be more of a thyroid cancer or not a thyroid cancer. And those aren't generally available in Canada for the most part. There are some companies in the US offering some molecular testing, but they're privately done and they cost money to send. And my patients don't usually do this, but there are some homegrown genetic testing in certain areas of Canada that are being offered currently clinically, and you may want to talk to your thyroid doctor about that. But you're asking about ThyroSeq, which is one of those American private tests that you can get. That most people have to pay out of pocket for. And that would sometimes help, not always, in the right specific person. And it's really important that we know what the pre-test diagnosis was, so what that biopsy said, because not all biopsies that are indeterminate are good for this test, but some biopsies may be helped by giving it a little bit of a push to say, no, it is more suspicious than we think or less suspicious than we think.
Well explained. Thank you. The next question asks, some people with substernal nodules say that after RFA, the lower part of the nodule moves up, and then in another 9 months, they do another RFA procedure. Do you have studies about that?
We don't have studies, but certainly, yes, if there's a small rim of substernal component of thyroid nodule, then you could potentially do a thyroid RFA on that nodule and then do it a second or third time. But the problem is that the thyroid nodules that are predominantly under the breastbone, where there's a smaller area in the neck, but the bigger area is under the breastbone, kind of like when we think about, big, huge icebergs, like the iceberg that took down the Titanic, for example. There was not a huge iceberg in the water. They didn't see one, but under the water was the huge iceberg. And I think that's the concern that we have for patients that have most of their thyroid nodule underneath the breastbone. Those nodules won't come up adequately for us to be able to RFA them. So those wouldn't be good candidates. But certainly a patient that has the majority of their thyroid nodule above the breastbone and a tiny little rim under the breastbone, or a little bit of a rim under the breastbone, that would probably be more of an adequate patient to do for RFA.
Thank you. The next question asks, what is the frequency for nodules to regrow after RFA?
That's a good question. I think it depends on the study that we have. Because it's only been offered for about 5-6 years in the US and about 10 years in East Asia. We don't have long-term data on which are the specific patients that regrow, but so far a lot of the data is showing that people have durable result from a symptomatic standpoint. So even if they have a little bit of regrowth, if your nodule goes down by 75% over 6 months to a year, then even if you have a little bit of regrowth, you likely won't have any more symptoms. And that's kind of the idea. You're doing this for symptoms. So the fact that it looks really big in your neck, or the fact that it's pushing on your throat, causing the symptoms we talked about before, that would be a good indication for RFA.
Thank you. Another question asks, do you have restrictions about proximity to the RLN?
Good question. So the question is about the recurrent laryngeal nerve, which is a nerve that runs behind the thyroid gland and goes to the vocal cord, and it moves. It's the main nerve that moves the vocal cord. And if you don't have a function of that nerve, then your vocal cord won't move and your voice will be hoarse. And this is a small risk of thyroid surgery and a risk of anything that you do in the center of the neck. Now, the technique of doing RFA is very clear. So if there is a nodule that predominantly lies right at the area where we know that recurrent laryngeal nerve lives, that nodule most likely, if you do target with RFA, you're not going to be able to get the part, or at least the majority of the part that's closest to the nerve. And there are some ways that we can actually try to get that area of the nerve away from the nodule, which is a little bit tricky and some fancy techniques. But by and large, if you have a small nodule or smaller nodule that's in that tracheoesophageal groove, which is the quote unquote the area, the danger zone, we don't usually target those for RFA in most circumstances, unless we do some fancy techniques.
Great, thank you. I think we have enough time for maybe 2 or 3 more questions. So the next one asks, when you suffer from hypothyroidism or an autoimmune disease, you basically live on the pill. Would that be the case after surgery?
I'm not sure what you mean, but certainly people that have hypothyroidism, many of them do need thyroid pill, either long-term or short-term. And that's a bit of a different scenario than surgical hypothyroidism. So in patients that have a thyroid nodule that requires surgery, either taking out half or the whole thyroid, if you take the whole thyroid out, certainly you'll need thyroid pill for the rest of your life. If you take out half the thyroid, about between 20% and up to kind of 60 to 70% of people need a thyroid pill either for a part of the rest of their life or the whole rest of their life to supplement the other side of the thyroid. And some of the studies that we show actually probably say that patients that need a thyroid pill after thyroid surgery may have needed one anyways, but taking the thyroid piece of the thyroid out would have shortened that timeline. So you may have needed a thyroid pill at 10 years later, but because you had thyroid surgery, you needed it 10 years earlier. So that's something that some of the studies actually show may be the case. For RFA, The reason why RFA is so becoming so successful, especially in areas outside of Canada up until this point, is that when you do RFA of a thyroid nodule, you're not RFAing or you're not ablating any normal thyroid tissue. And so that's why patients that have RFA for thyroid nodules don't usually need a thyroid pill, which is a bit different than the patients that have thyroid surgery. That being said, if you have thyroid surgery if for a benign nodule, then only 20 to 30% of patients need a thyroid pill long-term after surgery. So there are a bit of risks benefits in every one of these procedures.
Great explanation. Thank you. The next question asks, if a person is on methimazole, hopefully I pronounced that right, and a beta blocker, how long would it take to be off the medication in order to do an uptake scan to see if there are hotspots and where they are?
So that really depends on what the reason for being on that anti-thyroid medication is. So we talked a bit about before. So people that are usually on those medications often have Graves' disease. Graves' disease is an autoimmune disease that affects the thyroid and causes hyperthyroidism. And in those patients, unfortunately, RFA is not a treatment that we can offer. Patients that have Graves' disease can either have ongoing management with their anti-thyroid medication, or they can get definitive therapy using either radioactive iodine or surgery. And there's a large literature now actually promoting surgery as something that actually helps patients from a quality of life standpoint quite well. But Graves' disease, unfortunately, is not a reason for RFA, and your doctor would be able to tell you if you have Graves' disease. If it's a thyroid nodule that you have, then certainly you'd want to make sure that you have a nodule, and that would be done through ultrasound. And very often patients that have hyperthyroidism will get an ultrasound, and that would show a thyroid nodule or just multiple thyroid nodules, in which case those patients probably would not meet criteria for RFA, because if you have to ablate the entire thyroid by ablating all the thyroid nodules throughout the thyroid, then you basically just done what you could have done with surgery, and that actually had a durable cure. Because as we saw, only 50% of people have good thyroid levels after ablation for a single nodule thyroid. And that's related probably to the fact that there's multiple thyroid nodules. Being off the thyroid medication before you can get an uptake scan, I think it really depends on what medication you're on. And I would just talk to your endocrinologist about how to do an uptake scan. But most people are usually getting an uptake scan at their diagnosis of hyperthyroidism.
Great, thank you. So I'll ask one last question. It's a two-part question. I'll ask the first part first. So when you're referring to the size of thyroid nodules, are you referring to the longest diameter rather than 2 or 3 dimensional size?
That's a good question. I mean, I think that I conflate the two, and I think I should, and I shouldn't, because I'm thinking about it in my mind in a certain way. But certainly, we usually use volume as a way to decide how big the thyroid nodule is, and that's why I didn't mention. That's why when someone asked me, "Is there a size limit for a thyroid nodule that can be amenable to RFA?" There isn't, because really it depends exactly what this person, this questioner is asking. There really is no largest dimension or whatever that actually prevents you from getting RFA. It's really the volume of the nodule that will be decreased over time. And again, the issue with people that have big thyroids is that many times it's in the majority of thyroid is under the breastbone, which we can't see with ultrasound. And so the patients that have thyroid nodules where the majority is under the breastbone, those wouldn't be amenable to RFA. But patients that have large thyroids, doesn't matter how big they are specifically. If they're very, very big, then often you may need multiple treatments. But certainly, the ideal would be, about 4 centimeters or so would be an ideal candidate that would usually respond to one treatment that's above the clavicle. And that would be the greatest dimension. But when I say 4 centimeters, I kind of mean like 4 centimeters all around. So 4 by 4 by 4 kind of thing. And that would be kind of a nice size nodule that would likely be amenable to thyroid RFA.
Thank you. And the second part of that question is whether location of the nodule, the thyroid nodule, is a factor for possible symptoms or complications?
Sure. Like, so yeah. So as was mentioned before, the location of the nodule, if it was really tucked up beside the esophagus and the trachea and the recurrent laryngeal nerve, which we talked about before, if the majority of that nodule is in that zone, then that'd be a bit more tricky to make sure most of the nodule has been ablated. So you may not have as good of a result unless we still would do some fancy techniques to make sure we ablated as much as we could. But the nodule that's a bit further away usually would have a little bit less risk of that, and less risk of, some people feel a bit of like stickiness in their throat after the RFA, especially for nodules that are right on the trachea and the esophagus. But usually that's gone after about a week or so anyways. In terms of the results, I mean, I think it really doesn't matter within the neck, as long as it's in the neck and not majority in the chest, as I mentioned before.
Thank you. Are you comfortable answering one more question?
Sure.
Okay. Someone asked about the cost comparison between open thyroid lobectomy and radiofrequency ablation for management of thyroid nodules.
Yeah. Cost comparisons is a really important thing, and I think, you know, as we start to have more people, put more people in higher ups in government agencies and other funding agencies kind of understand these things, I think it's really important that we provide research for it. And one of the aims of my research is to actually try to show that some patients actually save the system a lot of money by having RFA versus not. And that's not necessarily related to the procedure itself. It may be related to long-term follow-up. So for example, if you have a small suspicious thyroid nodule that may have been biopsied as benign or indeterminate, and you're offered surgery, then perhaps under a study, and we treat this with RFA, and that nodule kind of disappears, then you may not need to do ultrasounds every year for 10 or 15 or 20 years, and that may save the system money. So I think there's a lot of cost comparison questions that are out there. And, you know, my advocacy is that I'm trying to get, you know, as much support for patients with thyroid disease as we can from both hospitals and governments, because as many of you know, there's sometimes a little bit of slower movement than we wish, especially illustrated by the fact that I couldn't get RFA to come to Canada. It took many years. So I think it's really, these are things that, you know, with your all support, really is helpful to push these needles forward. So thanks so much.
Okay, great. Thank you so much, Dr. Pasternak, for taking the time to answer all our questions. And I think that wraps up our Q&A.
Actually, Andy, we're getting some pretty good questions.
Sorry, in the chat, or?
I think we could do a couple more questions. Dr. Pasternak, would you?
Yeah, of course. Yeah.
Let's take a few more.
Sure.
Okay, there's some questions about you in particular.
Oh.
Are you training in the different provinces in Canada to do this procedure?
Am I training people? Yes. So we're running a course. We're going to be running a course to me and a few of my colleagues are going to be running a course to train as many people. You know, it's going to be a bit of a time, but we're going to try to train as many people across Canada to do this, because I'm just one person, so I can't ever dream of doing everyone that needed to be done across Canada. Although I do sometimes see patients from other provinces that don't have access to, and in other areas in Ontario, they don't have access to somebody that has an endocrine surgical background. But certainly that what we're going to do. And I'm also going to be hopefully, you know, helping set up programs across Canada, because I think that's really the important thing. That's how it ran in the US, and they were able to set up multiple programs quite quickly. And I'm hoping that's the case for Canada too.
Thank you. And someone asked if a patient can be referred to your group, and is there a waiting list?
They can, and I can speak offline to them, and I can touch base with Laz about how that works. But certainly Laz can probably also, and the rest of you can also mention to people where they can get this RFA potentially in their own area if it is available. And I'll go through, I don't have the list right now of who's going to be setting this up soon, but I will share that. but certainly we have a bit of a wait list, but it depends on for what. So we do triage things based on the need. And as we just started this about a month ago, so as we kind of increase our capacity, we'll probably be able to kind of get more people in kind of sooner rather than later. So that's kind of the ideal. That'd be the ideal, and we're starting to do that right now.
Thank you. Why in Canada is it so hard to get approved for advanced equipment or meds than Europe and the USA?
That's a good question. I mean, I think there was a big delay during COVID. A lot of stuff kind of slowed down through the regulatory process, and that was something that we got caught up in. In general, Health Canada is usually quite good about getting stuff through, and I think during COVID it was just a bit of a hard scenario. But yeah, no, I think we do require, and I think it's about managing safety and access. I'm not part of Health Canada, so I can't speak for them, but I certainly try as much as I can to advocate for my patients as much as possible. And I'm happy that we're able to kind of get this through over the last kind of couple of years.
Thank you. What is the process for out-of-province patients? Is it available to them?
Yeah, again, so out of province, I can touch base with you about what the options are in terms of around your area, but certainly we do see out of province patients if that was something that made sense for you and your thyroid team, and usually we can be found through our website or online. There's an intake form, and that would be the way to do it.
Great, thank you. There are a few questions asking for your email address.
I did set up an RFA email address. It's thyroidrfacanada@gmail.com. And that would be for general questions. It's not a medical email address. It's just for like some information stuff, because I was getting a lot of emails through my office, and I think it's probably better just to have it a bit separately. So this is not for medical questions. This would just be for kind of information purposes that are not related to your personal medical issues. So that'd be just thyroidrfacanada@gmail.com, and we're going to try and bear with us in terms of time. So I'm already getting a bunch of emails there. It's hard to be I didn't know that I was going to do this. I didn't know that I was going to be the first to do this, and it's going to be like the center of this. So I apologize if we're not the timeliness is not as ideal as possible, but we will work with Laz and the rest of the group at the foundation to try and facilitate your questions as fast as possible. But that would be the email address to use, is thyroidrfacanada@gmail.com.
Thank you.
Thank you, Anita. Let's it's a good place to stop here. So I'll just do my little I'd like to thank Dr. Pasternak for giving us his most interesting and informative presentation. We would like to show our appreciation by awarding Dr. Pasternak with a membership to the Thyroid Foundation.
Thank you. That's awesome. That's great. I'm very excited. That's great.
I would like to thank our webinar team for making this educational event a success. Special thanks go to StarMed for creating the RFA device that will greatly improve treatment of thyroid nodules, and to Symtomatic for being the exclusive distributor of StarMed's RFA technology in Canada. I'd like to mention, if you have some spare time and would like to volunteer to help others with thyroid disease virtually from home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member or making a donation, or by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. You'll also have an opportunity to enter your comments. This will help us improve future webinars. Please note that our thyroid cancer patient panel webinar scheduled for May 28th with Dr. Veena Agarwal has been rescheduled. Our next webinars will start again in the fall. All of us at the Thyroid Foundation of Canada wish you and your families a great summer. Thank you very much. Thank you, everyone.
Thanks so much for having me. Really an honor to be here, and I really appreciate everybody coming today. Thanks very much.
Thank you. It's a great session. Thank you.
Bye-bye.